All right. Well, hello, everyone. Welcome to another installment of CPC. Happy Valentine's Day. Today, we're all married to the game of medicine, right? So we're going to come here and celebrate that together. Very interesting case for us today. And so we'll go ahead and get started. Our one-liner is the case of a 57-year-old female with a history of anxiety, presenting with nausea, vomiting, and abdominal pain. And before we jump into the case, I'd like to introduce our faculty discussant, Dr. Kapuria, and I'm going to pass it on to you. The patient who came in, again, with anxiety history, but came in with nausea, vomiting, and abdominal pain. On further history, this has been going on for about 2 weeks and has had kind of constant difficulty with PO. So stating that, anytime I advance my diet and I eat more solid food, I get more full, more bloated, and then has postprandial emesis within an hour or two after eating. And the symptoms improve with emesis as well. Intermittently has been reporting some constipation, usually days at a time, and then has a small bowel movement. Last bowel movement on this presentation was 3 days prior. Does note she's passing flatus. Went to the ED 3 days prior to coming into this current presentation and did have a CT at that time with a little bit of the description. We'll cover the actual imaging later, but with some thickened loops of bowel, sort of nonspecific and called possible enteritis. And she was sent home at that time. These are the pertinent details. Nothing really outlandish here outside of being a current pack year or 23 pack year smoker, but on no medications, no surgical history, no significant family history. And then review of systems, again, mostly remarkable for these abdominal complaints, diffuse distension, pain, constipation, and intermittent nausea and vomiting. No constitutional symptoms, no fevers, no other sort of crazy infectious symptoms. And again, this has all been present and relatively progressive over the last 2 weeks.
Can you guys hear me with this mic? Okay, cool. So was the CT just a CT of the abdomen or?
It was just abdomen and pelvis, yeah.
Abdomen. So, thinking about how to, is it on?
You can move it up.
Okay, let me see if I can move it up even more. Is this better? So thinking about how you approach someone with, I would say, subacute nausea, vomiting, and abdominal pain. If someone like this comes to the ER and yes, they give you this amount of history, postprandial nausea, emesis, improvement after emesis, you should be concerned about an obstructive process, okay? Could be a mechanical obstruction, could be a non-mechanical motility-related obstruction, could be a host of other things, but if someone comes in with pain, nausea, emesis, postprandial emesis, and improvement, that is something I would think about. Very rightly, she was scanned in the ER. There's no gastric distension, just some non-specific enteritis. So I'm less concerned that, oh, there's a gastric outlet obstruction going on that I need to fix right away, which is when I get time to do a more detailed, so there's no surgical need to intervene quickly. So now I have a few hours to think about my differential. We already got enough information, including imaging. I think the next step would be to kind of try to get a more prolonged social and medication-related history. Any reason she could have peptic ulcer disease, any reasons she could now have developed gastroparesis. All of this is very subacute, so there's thing very chronic going on. Did she start a new medication? I'm looking at GLP-1, GIP analogs. People, even now, interestingly, aren't very familiar with or don't expect the side effects to be so hard-hitting. So those are the initial things I would think about before moving forward with the labs to begin with. Make sure that there's no electrolyte disturbances with her nausea and vomiting. I would also ask for any weight loss that's been going on.
Yeah.
The other thing that concerns me is the smoking history and the family history of lung cancer. When we come to cases like this, they start thinking about zebras. There are a few zebras, but I'm not going to talk about them right now. So I would start off with labs.
Yeah. And so we'll get there in a second. I am curious, we do have patients like this. She had actually been even a couple weeks prior when this initially started, went to an outside hospital ED, had very similar findings on CT imaging. We didn't have access to those actual images. But when you see terms like enteritis thrown out, I mean, in my mind, that's very nonspecific. Are these patients that when we see them and, say we send a number of patients for scans in our primary care clinic, should we be rushing to antibiotics? Is it relatively nonspecific? How serious or worried do you get when you just see that terminology?
I'm not very concerned unless the patient's starting to hit SIRS criteria. I wouldn't jump to antibiotics if, especially this patient is really presenting with upper GI issues, doesn't really have any lower GI gastroenteritis or diarrhea-like symptoms for like a localized area of small bowel wall thickening, which is basically what I would call this. I mean, our radiologists sometimes put in things like correlate clinically. This could just be under distension. So I would consider all those things before giving her a bunch of antibiotics and sending her.
And does the absence of diarrhea here kind of push you away
Yes,
from an infectious etiology?
It does. And also, she's afebrile. I'll wait for the white count to see if that's gonna change or like figure in my further management. But if she does have some leukocytosis, I may think about antibiotics. If she gives me any history of sick contacts in the recent past, I may think about antibiotics. But other than that, for now, I would leave that non-specific small bowel wall thickening alone.
Got it. Okay. No, that's very helpful. And no other new medications to note, no recent sick contacts. And we'll start with a physical exam and then give you some initial labs. And so this is our initial physical exam. Patient's afebrile, normal heart rate, normal blood pressure, 111/57, and really only remarkable for abdominal findings. So mild pain on palpation, mainly in the upper epigastric region, but no rebound, no guarding. Had distension, but no fluid wave noted. And for our initial labs, we have the following. And so remarkable for a very mild leukocytosis, mild neutrophilia, but otherwise relatively unremarkable. A1C was normal.
Okay. What is her extent of inability to tolerate PO?
It's a good question. So what's really been happening is she can tolerate kind of a small liquid diet for a little bit, but then every time she's tried to advance and eat more solid foods, that's when she becomes intolerant. And that's been pretty consistent over the last 2 weeks.
One question that I always ask patients, and this is more of an outpatient evaluation, but I think her symptoms are subacute, so we could potentially ask her to, what is her definition of emesis? Often patients will tell you that they are throwing up, but you also need to consider they could be regurgitating. They could be having something like rumination, which are due to esophageal or not like distal gastric etiology. So it's sometimes good to ask patients, hey, do you actually get the sensation of throwing up, or do you just bring up some food in your mouth and spit it out, which would change your management of the patient? In her case, it sounds like she was actively throwing up or had emesis.
Yeah.
The other thing you could consider if you're looking at our differentials is she's a smoker. This is postprandial pain, nausea, emesis. Do we need to look at mesenteric ischemia? And I would want to have our radiologists comment if for some reason it was missed, comment on any significant changes in her mesenteric vasculature, namely the celiac or the SM.
Yeah.
Since, okay, we can go to the imaging if there's more on the CT.
Yeah, so what would you, if you're seeing this patient, admitting this patient, what would be the kind of first initial workup you would do? Would you do additional imaging, being that it's been about 3 days between her initial ED visit, and I sort of gave you that initial finding of that nonspecific enteritis, and then today's presentation when she's actively getting admitted? Would you pursue repeat CT imaging right away, or are there other studies that you pursue? Yeah.
I would, since I'm a gastroenterologist, I would probably go for an upper endoscopy.
Okay.
So that is one thing. I would, however, I do like to look at the images myself, so I would like to look at that CT to look at is she having really slow GI motility? So is there a lot of food in the stomach? Is there a lot of stool in the colon or in the rectum? So those are things that I would want to look at. So I would like to see the CT imaging.
So
If there
we'll,
was a newer one, that's fine.
Yeah.
But in her case, if there was one 3 days ago, I would be happy with that and proceed with an upper endoscopy.
I'm going to pass down to our radiologist just to cover the first two CTs. So the one
So
on
you
the
guys
10th
did
and
get
the,
another.
yeah,
before.
there's two CTs. So we have one on the 10th. And then we have another one. And I did change the dates mildly so they don't actually represent the real dates, but the time course is the same.
So CTs here, and I think it sounds like I'm just gonna show the first two.
Yep.
And what I want to show on this one particular coronal image here, can you guys hear me okay? Usually people can, that's not my problem.
Just for the recording.
You could see here that we have a loop of jejunum, mildly dilated and thickened folds. Can you see? You can
Yep.
see my arrow. Okay, good. And this is a coronal view. And a good comment was made is that we should look at the celiac, the SMA, and the IMA. And they were all completely patent and really very unimpressive in terms of any atherosclerotic disease. So we're not dealing with a large vessel vascular problem. We still haven't ruled out a small vessel vascular problem. And this is, this is pretty nonspecific. We've got one loop of jejunum that looks kind of unattractive. Okay. And it looks like we moved the dates around. So let's see if I go to the next slide, what happens. This is same day. And you can see also some of the more proximal loops, a little bit dilated and folds a little bit thickened. And if you look over here in the ileum, here's the cecum and the ileum. The ileal loops are normal in caliber and they're decompressed. So we have a difference in caliber. Our jejunum is dilated and our ileum is decompressed. So we're starting to worry about a small bowel obstruction. Now, here we are a few days later. Now, only people who are really ill would keep coming to our ER every 4 days and getting a CT scan. Like, you'd have to be crazy to do that if you weren't in severe pain. And you can see here, the loops are looking a little different. Here again, a very dilated loop with thickened folds here again in the jejunum. And again, the ileum looks a little bit more decompressed and normal in caliber. Should I stop here?
Yeah.
Okay,
Yeah,
so where we're left with is we have dilated small bowel loops and thickened folds, which is a different differential than just small bowel thickened folds. Small bowel thickened folds throughout the small bowel, we could be thinking of a small vessel vasculitis like lupus or HSP or something infectious or even hypoproteinemic. But when we're starting to do with dilated small bowel loops with thickened folds, we're really moving into some sort of mechanical obstruction, something that's waxing and waning. I don't know if it's an adhesion or a mass that's prolapsing in and out of the jejunum or an internal hernia that's prolapsing in and out. And as she gets more and more obstructed, that particular loop gets thickened and edematous. So that's sort of where we're headed, but I just don't know what the cause is. I haven't figured it out yet. Should I go sit down?
Yeah, it's perfect. Thank you.
Are we seeing any transition points?
Yes, yes, it does. It sort of eases in transition. And on one of the other studies, there's even more of a transition. But when I look at the transition, I don't say, oh, wow, there's a big jejunal cancer, or there's a big necrotic mass, or I see an internal hernia going through the something or other. Yes, there's a transition, but I still can't exactly explain what's going on. So sort of helpful.
So what would your next steps be from this standpoint?
Consult surgery. So I think, yes, it is a good time to have surgery on board because this is starting to look like a mechanical obstruction more than anything else. It is a rapidly progressing obstruction, so it's not like, oh, 3 days ago things were about the same, but now, and they're still about the same. There is dilation that we are seeing right now. I didn't see a bunch of stool in the colon either, so I'm not very concerned about, oh, this could be an ileus or a pseudo-obstruction like picture at this point. So I would, next step is mechanical obstruction, which is progressing at a decent rate. What would you think about in terms of etiologies for mechanical obstruction? Of course, adhesions, big possibility. She doesn't really have any abdominal surgeries, not like adhesions do not develop without surgeries, but that is something to think about. The second thing would be malignancy or cancers. I didn't see any enlarged lymph nodes around that area. So I'm less worried about a small bowel lymphoma. Those small bowel polyps and de novo small bowel tumors are pretty rare, so I'm not very concerned about those too. There are certain small bowel polyposis syndromes that can, such as Peutz-Jeghers, that can give you polyps this large that they can cause mechanical obstructions, especially if polyps are prolapsing. The obstructions can wax and wane. So I'll keep that in the back of my mind. Coming to inflammatory causes and infectious causes. No reason, she's not immunocompromised. I don't see any big reason for, oh, will she have a fungal or weird infection in her small bowel that would cause obstruction? So then does she have something like Crohn's disease? And if that is the case, he's 50. It's kind of a somewhat later date of onset. The rest of her small bowel doesn't really show anything else. Maybe worthwhile now at this point to get inflammatory markers, so a CRP and maybe a stool calprotectin, even though in the absence, well, I shouldn't have said more. So she does have an elevated stool calprotectin. CRP looks okay. Lactate is fine. All right. Elevated fecal calprotectins don't always give you a slam dunk diagnosis of IBD. It is an inflammatory marker, so can be elevated in infectious etiologies, even in something as insidious as bacterial overgrowth, small intestinal bacterial overgrowth. So I'm still not jumping towards this is small bowel Crohn's. I think at this point, I would want to do a push enteroscopy at this point, with the hopes that I can at least reach some part of the jejunum, if not that dilated part, which looked a little further down, to see if I can get some tissue biopsies. Another thing that could be helpful in defining this more would be an enterography-based study, so something with a large volume of oral contrast if she's not at a very high aspiration risk. Upper GI series with small bowel follow-throughs are great, but we tend to do more things like MR enterographies and CT enterographies. So I would say maybe a push enteroscopy plus minus a CT enterography, or both of them, but I would do the enteroscopy first, and so that I have biopsies cooking or pathology cooking, and then either the same day or next day get a CT enterography for this patient.
Okay. I do want to first ask, with kind of the discordant ESR-CRP compared to the fecal calprotectin, we talked about it being non-specific, relatively sensitive for things like IBD. Do you expect the ESR and CRP to be significantly elevated in patients who have kind of active IBD? It would have this sort of picture.
For ulcerative colitis, it is more corroborative. For Crohn's, I have often, you may not have elevated CRPs. Okay. And ESR goes the same way as CRP. So serum inflammatory markers may often not be as elevated as your fecal calprotectin. As
so this remains non-specific.
This is discordant with an IBD.
Okay, wonderful. So let me move us back to our small bowel enteroscopy. Now, this was the findings. I will say no biopsies were taken during this study, and everything in the luminal side looked normal.
So the proximal jejunum looks okay, and I mean, push enteroscopies are hard, and if you have reached the proximal jejunum, I think you should mostly be happy if you can't get further down. Even if you can't get further down, that's fine. How about any imaging studies? Did she get a CT enterography or a upper GI series with small bowel follow-through?
So,
I would prefer to get a CT enterography in her case now, because upper GI series will only show me if there's like something like a band or an obstruction on
Yeah.
there. CT enterography will give me some more details about the walls of the small bowel.
yeah. So let me first just round out our infectious eval real quick. Couple of things were sent, they were all negative. And so most of these are etiologies of diarrhea, but they also thought of just other etiologies of that kind of generalized enteritis that would be common, and see if we could find an infectious agent. But all of this was negative. Now, they discussed a little bit of a case update. They had discussed doing, prior to the push enteroscopy, originally they were going to try to advance the diet and then have her follow up as an outpatient. When that didn't happen, they pursued the push enteroscopy. At that point, there was a discussion about doing the MR enterography, as you've been discussing. However, prior to that, the patient had a video capsule endoscopy. Now,
it's a dangerous game to play. Doing a video capsule before you are very sure about whether that capsule can actually pass. I'm hoping that the patient got a patency, especially if you're thinking about luminal narrowing. The capsule retention rates are anywhere between 0.3 to 3%, and the 3% are in patients who we are suspecting to have IBD, typically small bowel Crohn's. That's fine. I would suggest doing some form of imaging, but in this case, if we are deciding to do a capsule, do something called a patency capsule, which is basically a capsule that that's made of a barium plus wax-based compound that dissolves within 24 to 48 hours. So even if it's hung up at a stricture, it doesn't cause worsening small bowel obstruction. Okay, so we did a capsule.
so you are right to be concerned. And spoiler alert, the capsule does not pass. And so I'll first give you the results of the capsule. And I am curious, in your experience, how much time would you expect it to get to the cecum? And my other question is, when patients are given these capsules and it takes some time, generally the times that it's been delayed, we tend not to be concerned and eventually it passes. What is the expected time course for that? Do patients know right away when they've passed it?
Okay. Ideally, the capsule should be out. So it depends on your GI motility, right? I have patients whose small bowel transit time, which is the time from it hitting the duodenum, where you get your first small bowel image, to the IC valve, it's 3 hours, 30 minutes, 8 hours. Our capsule stops working after 8 hours. So anyone who's had more or a more prolonged small bowel transit time, we'll never know. So if we still see the last images of the capsule in the small intestine, we don't know whether we have completed the study. And we basically ask them we give the capsule around a week or so to pass, after which we ask the patient to get just a simple KUB. If the KUB doesn't show a capsule sitting in the abdomen, then we're good. Patients can sometimes see it in their stool, sometimes they don't. Some patients don't like to look. So if there are people that we are sending out with a retained capsule, we should get the imaging studies to confirm it's passed. In people with Crohn's disease that, unexpectedly capsules get stuck, and see, capsules getting stuck is not the worst thing on earth. A lot of times it means that a capsule is around 6 to 8 millimeters in diameter. And if you have an area of luminal narrowing that narrow in your gut, you're probably going to end up getting some sort of surgery if you do not have IBD. If you have IBD, then I have had patients who've had their capsules stuck, and I've been able to get them to pass after giving them a bunch of steroids to reduce inflammatory strictures. If you have fibrotic strictures, things are gonna get bad and the patient will require surgery, but they would require that surgery anyway in the next few months. So did I answer all this?
Yeah, no, that's very helpful. So to give you more continued case updates, while waiting for the capsule to pass, patients getting daily KUBs, it's stuck somewhere in the left lower quadrant. Doesn't appear to really be moving any further at that point. Sort of shifting in the abdomen. It was unclear initially, especially in the first few days, is it moving further or is it just shifting in the abdomen? It was just shifting in the abdomen. And at that point, they continued to try and escalate diet from clear liquids and liquids, and then she would have more emesis. And so that sort of continued to progress. And then at that point, we get 14 days out from the initial placement of the capsule and continues to have worsening pain, worsening distension, and continued intolerance of PO. And so at this point, what, sort of is your management strategy? And yes, GI may have kind of disappeared into the background at this point in the case.
See, now this is a catch-22 situation because the patient presented with mechanical obstruction symptoms. So now you don't know whether her continued symptoms are because the capsule is worsening her obstruction or it's just sitting there not doing much and she's suffering from her initial mechanical obstruction problem. If this was a patient with new onset nausea, vomiting after the capsule was stuck, this would need surgery. Now, in this case, abdominal distension and pain, she does need another CT. I'm not sure how happy I would be to give her a bunch of oral contrast now. I think it's 300 something mils of contrast for a CT enterography, but I could be wrong. Yeah, it's like a lot of volume, and now that I'm worried about a capsule also sitting there and obstructing things, these people aspirate, and that complicates things even more. So I would just get a regular CT to see is there any evolving ischemia of her small bowel now because of that capsule plus her ongoing process.
So I will get you another CT.
Does she chest X-ray?
No, she did not get any chest imaging. Yeah, it was never short of breath. It was always clinically stable. Frankly, at this point in the course, understandably, patient was very frustrated. Felt like we don't have an etiology. Capsule's not passing. I came here for what was going to be a couple of days, and now, I'm still intolerant of PO. What's sort of the answer? And so we'll get to that in a second. I am curious. We've talked about mechanical obstruction. This picture now kind of sort of declaring itself. Any other thoughts as to the underlying etiology in a patient who has seemingly an obstruction in the small bowel?
Any other idea other than adhesions, Crohn's disease, infections, and small bowel adenocarcinoma or small bowel polyps? I think metastatic lesions, which is why I asked about her chest X-ray and her history of smoking. Does she have lung cancer with small bowel mets? But and I also looked at her imaging. It didn't look like she had any lymph nodes that could suggest small bowel lymphoma. I really can't think of, yes, we all look at, is this a fungal infection sitting in her small bowel? Sure, but that's again a zebra. I wouldn't call that something that I'm actively thinking about.
Yeah, you can go through the rest of the imaging at this point.
Okay, so we're back here on a different date, a different CT. This is a non-contrast CT. And I'm just showing this coronal image to show it's relatively unexciting. The small bowel loops that were dilated and thickened are less impressive. Again, whatever this process is, seems to be waxing and waning on a regular basis. Then after that, here we are again, just 4 or 5 days later, and we're back again. Here with these dilated jejunal loops, the thickened folds, the decompressed ileum, and in a small bowel obstruction. Again, no specific mass is seen at the root of the mesentery, but something's going on that is intermittently causing a fairly high-grade obstruction. And then here we are, again, I'm on this 12-4, I'm just showing an axial view here, where these dilated loops, and everything sort of comes together here and sort of coalesces with a little area of irregularity and abnormal enhancement.
Is there, I can't see the capsule there.
I didn't take a picture of the capsule, but in fact, and one of these images, it actually went retrograde in the wrong direction. So it was heading back up toward the jejunum as opposed to down the jejunum as it was sort of wafting through the small bowel. But I'm just showing here this area of irregularity here in the distal small bowel with some abnormal thickening and enhancement. You know, whether I don't think that that's due to Crohn's disease. I usually think of Crohn's disease more of a really a sort of a terminal ill and not so waxing and waning every 4 days. It's not a good look for it. It's not a absolute no.
I think it wouldn't, like, I think Crohn's, especially if she's not getting treated with steroids,
Later.
Oh, sorry.
there's no reason for it to go away and then come back.
So
Well-
I think you've hit really everything as far as the differential, and I think that your management has been spot on with sort of matching the course of this patient, and I think sort of even potentially avoiding some of the complications that arose in this case. And I will say, I think in reading through this case, I would just say I commended all the teams involved, and I'll get to a little bit more of the updates, but it was very clear that the primary team was advocating for this patient every single day as to something is going on, something doesn't make sense here. There were multiple discussions about, hey, discharge follow-up is outpatient. We'll kind of see this evolve, but continue to not be able to tolerate PO, advance that diet, and otherwise was previously healthy. A 57-year-old patient who's had 3 weeks now, 3 to 4 weeks of just complete intolerance of solid food. And at that point, there was a discussion with surgery because of the evolving small bowel obstruction.
So I would actually have been more insistent about surgery getting involved 7 days before that, like not at day 14, but at day 7, because now we have a stuck capsule, obstructive symptoms, and she's not able to tolerate PO. She doesn't have any of those risk factors, making her a high risk sedation or surgical candidate. So she's like the perfect person to at least do a laparoscopy on. So I would have. They
No,
didn't
you've been right on it. So that was the discussion. The discussion was, she's having this evolving small bowel obstruction. Now we need to go get the capsule. It's moving in the wrong direction, and patient's frustrated and wants an answer. So they go in and they do an X-lap, and it was an interesting discussion, right? You're having a discussion with a patient. We may not find anything. However, that is not the case. So they go in and they note dilated small bowel proximal to that mid-jejunum and noted a stricture at that point. Then they removed 5 centimeters, both distal and proximal, and sent the specimen to pathology, which will sort of reveal what the etiology of that is. And so I'm going to pass it over to our pathology colleague to go through those pathology findings.
I'm one of IMPACT fellows. So for this patient, we received a segment of a small bowel, and when it was opened, there was some stricture. These are H&E section from the area of the stricture. This is the picture on the right side is one of the full section. You can see the epithelial lining, the intestinal mucosa on the top. There seems to be a proliferation of atypical lymphocytes, as you can see in higher power, in the submucosa, going all the way to the serosa. And as you can see, there are predominantly a small lymphocyte. They have some irregularity in their nuclear contour, but it's not very prominent. There are some hyaline vessels in the background. These are our ISC. We basically throw some stain to find the nature of these cells. CD3, something that highlights the T cells, and CD20 highlights the B cells. And you can see there are some T cells in the background, but majority are CD20 positive B cells. And to further characterize this, because this was a small atypical B cell proliferation, one of the things is to find out if they express CD10 or 5 based on different pattern of expression, different subtype of lymphoproliferative disorders can be like the main pathology. Here you can see none of these atypical B cell express CD10. CD5 is expressed in some cells in the background, but these are T cells. As we compare it with the previous image, there are some scatter cells, but the majority of the cells in the background don't express CD5, which are our atypical cells. And also these cells express BCL2. And the Ki-67, which is like proliferation index to tell us in majority of the time how aggressive this lymphoma is, as we can see here, is very low. It's like 10 to 20%. So combination of all morphologic characteristic, immunophenotypic characteristic, and the fact that Ki-67 is low, this is consistent with marginal zone lymphoma and resection margins of peripheral lymphoma.
Awesome. So any additional thoughts based on that? Just this impression now.
So isolated small bowel lymphomas, I mean, we talked about it, are pretty rare. Typically with lymphoma in general, you do see enlarged lymph nodes, but isolated small bowel lymphomas, we'll see if it's isolated or not. I'm assuming there's going to be a PET CT at some point in our future. They are very rare, and as we saw today, they don't really show up with a lot of other symptoms or positive diagnostics other than what this woman came in with.
Yeah, well,
I'm not sure why it was still relapsing and remitting in terms of the obstruction, other than the fact that maybe there was the lymphoma. I don't know why the stricture was relapsing and remitting.
I think she was going through periods of not eating, to be honest. I think that helped to decompress things and wasn't adding a lot of solid contents on top of what she was eating. But thank you so much for your discussion.
Yeah, learning points are if people have a history of abdominal or intestinal surgery and you want to look at their small bowel with a video capsule, try to get a patency first. I think in this woman's case, though, the capsule actually helped her diagnosis inpatient versus going out and being treated as this intermittent obstructive etiology. It would have pushed her back a few weeks to months. So yeah, whoever did it, it worked out well.
Yeah, well, thank you very much. And so you are correct. Fortunately, this patient actually has had no disease recurrence. PET scans have all been wonderful. Margins were negative, and she had the end-to-end anastomosis in the initial hospitalization and has done well. In terms of a quick teaching topic, so marginal zone lymphoma, we tend to think of these like multomas being in the stomach more specifically, but they can occur anywhere along the gut, along with other areas of mucosal associated lymphoid tissue. And they actually tend to be relatively indolent. Outcomes tend to be pretty good, and in part because the areas that they occur in tend to cause symptomatology. And so people present relatively early in their course, or early enough that they oftentimes do not metastasize, and people can do pretty well. It's thought that it's chronic immune activation and sort of these bouts of infection and inflammation that can help to trigger this, but otherwise it's not totally clear. But those B cells tend to be much more differentiated, the ones that are in the marginal zone of lymph tissue. Thank you very much.